Welcome to this presentation entitled Special Considerations in Acute Pain Management, Opioids and Their Place in Dentistry. My name is Brian Oglander with Southwest Oral Surgery, and this presentation is basically an amalgam of the information that I obtained in trying to get my 8 hours of CE regarding opioid and substance abuse and opioid and proper management and proper prescribing methods. In dentistry was the DEA requirement that we all have to meet the 8 hours of CE prior to our new DEA renewal that comes up by 2025. So let's get right into the next slide and what we're going to review. We're going to review how we got here, an opioid crisis review. We'll review terminology and pharmacology of opioids, the narcotic minimal pain management algorithm, and some recent changes in opioid regulations. I have no disclosures and no commercial affiliations. If you'd like to learn more, we do have a website, southwestoralsurgery.com, and we do have numerous classes as part of an education portal for dentists. You can check out some more there. Some statistics: nearly 92,000 Americans died from a drug overdose in 2020, and of these drug overdose deaths in 2020, 75% involved in opioid. And this is information from the CDC.gov's website. And a study from National Safety Council in 2017 came up with this statistic. You have a 1 in 96 chance of dying from an opioid versus a 1 in 103 chance of dying from a car crash. So you're now more likely to die from an opioid overdose than a car crash. It's how prominent opioid deaths are becoming. So the United States represents 5% of the world population, yet the U.S. alone accounts for 80% of the world's oxycodone consumption and 99% of the world's hydrocodone consumption. So really, how did we end up here in the United States? There was an article that came out. It came out in the Washington Post in 2019. And what this article did was utilize information from the DEA database. And the DEA kept a log of where every opioid prescription went from distributor to pharmacy. And what they found was over a 7-year period between 2006 and 2013, the U.S. was saturated with roughly 776 billion pills from manufacturers and distributors. And just 6 companies distributed 75% of these pills from 2006 to 2012. And here's some of the big ones: Walgreens, CVS. So how did Big Pharma and these big drug companies, how did they infiltrate our society? They did that through multiple different means. They did that through co-opting academic physicians, getting involved with the professional medical societies, the regulatory agencies, the Food and Drug Administration. And the way they did it was coming up with their own studies and utilizing these studies to convince these agencies and professional bodies that, yes, these drugs, these opioids were safe, and yes, they were needed by patients, and how could doctors withhold them? And basically the academics and societies believed and pushed the narcotic prescribing through the roof. Dentistry had a part in this as well. Dentists account for nearly 1/3 of the opioid prescriptions for those aged 11 to 19-year-olds. This is from a study in 2019. Large majority of these are probably patients that were undergoing some type of surgical procedure. Usually the most common age for wisdom tooth surgery is 15 to 20, so I bet a lot of these were people seeing an oral surgeon, getting a prescription. And the issue with this is, if you look at how the literature illustrates opioids and their misuse, exposure to an opioid before completing high school graduation is independently associated with future opioid misuse amongst low-risk children. So these kids that get introduced to this, it changes brain chemistry somehow, and ultimately we get patients that are now misusing the opioid. So we went from opioids for everything to opioids really for nothing. The opioid crisis has really changed regulations and how dentists should be prescribing. And so our modalities are going to change. And In order to understand how we're changing and why, we want to really review opioids, some of the terminology and the pharmacology behind these medicines, now that we know how disruptive they can be. First term we're going to talk about is dependence, and this is when the body accommodates to the influence of a drug. And upon sudden discontinuation, the patient will experience signs of withdrawal. And physical dependence from narcotics affects the part of the brain that oversees the autonomic functions. And autonomic functions include breathing and things that we really don't think about. However, the patients still are in charge of their own decision-making skills. Even though they may experience some euphoria while using the drug, the reward center of the brain remains offline. They're still in control. Now, if this person who's dependent on the narcotic decides to discontinue the drug, they may suffer from withdrawal, and withdrawal symptoms include the irritability and excitability, depression, anxiety, and hallucination. So these people usually need to be weaned. Even though they're dependent on the drug, they can generally be weaned pretty successfully and then taper off the medication. Another term that we should be aware of is tolerance. Greater doses of this drug are required to produce the same intensity of effect as a smaller dose. What's interesting about opioids is the tolerance develops to the pain-relieving effects, the sedative effects, and the respiratory depression. But there's no tolerance that develops to constipating effects or the miotic effects, the pupillary constriction. So how this is an issue is if you have a patient and you're a doctor trying to treat somebody with terminal cancer and the patient develops constipation at a certain level of drug, opioid use, yet their pain is getting worse, their cancer is progressing. Really, it's very difficult to manage these patients because the patient is now no longer tolerant to the medication. The constipating effects are taking over and they just cannot take any more of the medicine. So management of the disease becomes very hard. And then we have the ultimate concern, which is addiction or substance use disorder. And this is a compulsive behavior centered on seeking the drug and its effects for non-medical reasons. It's an overwhelming need to accommodate the brain's reward center. Self-control and decision-making are impaired. The patient is really no longer in charge of making sound decisions. And it's a complex psychiatric phenomenon. It's really not attributed to the opioid itself. It's a complex disease, and it involves the brain and subsequently all kinds of different neurotransmitters with that. If we look at opioids, really their central effects are mediated within the central nervous system, within the brain and the spinal column. And the most important receptors within the central nervous system that we should be concerned with include the mu receptor and the kappa receptor. We'll just look at this mu receptor, morphine, any of the narcotics that we may prescribe in our office. Their main function is going to be at the mu receptor, and the effects that the mu receptor causes are pain relief, sedation, euphoria, and unfortunately some of the untoward effects as well, which are respiratory depression and the dependence issue. And we see the morphine is very, very high agonist at the mu receptor, and naloxone, which is the antagonist, is a very unaffiliated medicine for the mu receptor. So it antagonizes the effects, and then there's other drugs that are utilized in between. Some therapeutic considerations. Any narcotic is equally analgesic and equipotent if given in the appropriate amount. So though there may be some potency issues or differences in which narcotic requires less as far as dosing to have a therapeutic effect, at any given dose, any narcotic can be equally analgesic to another one. So for instance, if we look at these narcotics here, codeine, hydrocodone, and oxycodone, common narcotics prescribed in dentistry, we see that there can be an equally analgesic dose. We can also see that the liver plays a role in the function of how these medicines work, in particular the cytochrome P450. For instance, if you look at codeine, codeine is a prodrug where it really has no effect. It has to be broken down by liver enzymes to actually have its therapeutic effect. It's part of the reason why codeine is really not as therapeutic. Yet oxycodone, the drug itself, is the drug that's acting on the mu receptor, and it is very potent. It is very lipophilic. It really gets to the mu receptor and can bind readily. And once it gets broken down by the liver, it really has much less of an effect. And if we look here again with oxycodone, it is probably the most commonly prescribed and abused oral narcotic. Part of that was because of the manufacture of OxyContin, which was an extended release form of oxycodone. But it's highly lipophilic. It can easily cross the blood-brain barrier, 6 times higher in mouse models. It deposits heavily in the ventral tegmental area of the brain, and that's where you get all the euphoria, the dopamine spikes, and it's just almost 1.5 to 2 times more potent at the mu receptor. So do opioids really even belong in the management of pain in dentistry anymore? Really, non-steroidal anti-inflammatories should be our main go-to in dentistry here. We should be really limiting the amount of narcotics that we're giving patients, and in my practice, that is exactly what we're doing. Because non-steroidal anti-inflammatories are very effective in musculoskeletal pain. Often, unfortunately, though, they're assumed to not really be effective. But if you look at studies, and this was a study done by an actual drug company, they showed that if you give somebody oxycodone in combination with ibuprofen at 400 milligrams, it's the same almost pain relief as if you just were to use ibuprofen 400 milligrams. And of this, you should realize too, ibuprofen, its main pain ceiling is at 400 milligrams, so that's 2 ibuprofen tablets. You don't get any more pain relief from 3 ibuprofen tablets or 4. You may get anti-inflammatory effects, but you really don't get any more pain relief from them. But ibuprofen is almost equal in pain relief to oxycodone, 5 milligrams. And another slide which kind of illustrates this as well, but more importantly what it illustrates is the combination effect, which we should be making part of our armamentarium when we're treating oral pain in dentistry, is ibuprofen at 400 milligrams and giving somebody Tylenol 1,000 milligrams, which is an actual pain relieving effect from Tylenol. If you give those in combination, there's the two act together and they give better pain relief than oxycodone. So again, a stepped approach if you're managing postoperative pain or even just dental pain in your office. Ibuprofen in conjunction with Tylenol. Now you can add an oxycodone or a hydrocodone in combination with Tylenol if you would like for breakthrough pain, which is reasonable. But we want to limit our quantities of the medicine to roughly 6 to 8 for the first 24 to 48 hours, and realizing that given this narcotic in that 11 to 20 year age range where they're more susceptible to that initial first dose, that's something we want to talk over with parents. And there's other options too. Medrol dose pack to control inflammation, Exparel, which is a longer acting local anesthetic. This is an interesting clinical case. Had somebody who, 40-year-old male with a symptomatic decayed lower right molar, undergoes difficult extraction. Now he's got a history of reflux disease, and that's exacerbated by non-steroidals. And he also wants to avoid opioids. So here you got a case where you're really limited. You can't really use the non-steroidals as much as you'd ideally maybe like, and you certainly don't want to use opioids. So what do you do? And you consider suspension ibuprofen, basically children's Motrin, because it's in conjunction. It's not in the stomach for very long. It can't cause as much gastric irritation, maybe exacerbate the GERD quite as much. And you recommend that patients will take Pepcid AC, which is an H2 blocker to kind of help with some of the stomach acidity. Also, you consider Marcaine, ice, rest, things like that. But you just have to educate your patients, say there's really some limited options we have, but we're going to try with this. And what are the recent changes in opioid regulations that have come about? A couple big ones. Missouri Bureau of Narcotics and Dangerous Drugs, they actually have a really good website, and if you look at their website, you can find some interesting updates. They usually publish updates every 6 months, and I remember looking through the website, and one of the first updates I saw was related to the e-prescribing, and I'm not quite sure how many out in private practice are doing e-prescribing, but if you're prescribing narcotics and you're doing that pretty regular, most of the pharmacies are not going to accept a written prescription for a narcotic unless you have some type of waiver. And this whole e-prescribing thing came about through a state statute which became effective in 2019. And that statute said, beginning in 2021, no person shall issue any prescription in Missouri for any Schedule 2, 3, or 4 controlled substance unless that prescription is submitted electronically. And it doesn't hurt to check the DEA's website and see what kind of new updates are coming about. We all know about this 8 hours of CE that we need, and that requires practitioners to obtain CE related to opioid prescribing, in particular opioid substance abuse and treatment for substance abuse. And really this was part of a Consolidated Appropriations Act of 2023. And this is just a one-time requirement for DEA registered practitioners, and it went into effect in 2023. When you renew, if you're renewing your DEA up till 2025, you have to be able to prove you have these 8 hours of CE. And in case any of you guys didn't know this, there is also a new prescription drug monitoring program. So Missouri was one of the last states to finally get their act together and put together a drug monitoring program where a clinician can log in and see exactly how many narcotic prescriptions has their patient had, do they have a history of drug seeking. It was part of the Missouri Joint Oversight Task Force for Prescription Drug Monitoring that was created by a law in 2021 in Missouri, and it went into effect in December 23. And if you Google this and kind of go on their website and check out some of the information, you have to register with the Prescription Drug Monitoring Program, and then you can go and find information on patients as far as narcotics. Right now, dentists are not required to do this, but it may change in the future. And so these are some of the important aspects that I learned just getting some updates with narcotics and trying to change my practice, and really finding that majority of my patients, when I check on them after third molar surgeries and regular surgeries, are doing fine with just ibuprofen, over-the-counter medicines, and the large majority of them don't even want to fill the pain reliever. If they do, they wind up not using it. So things really have changed in dentistry, and I hope you guys will maybe see some of these changes and implement new things to your practice as well. Thanks again for listening, and if there's any questions, please let me know. SouthwestOralSurgery.com. You can check out our educational videos under the professional portal, and thank you.